Hello students, myself Dr. Ajith, Assistant Professor from the Department of Orthodontics from Vinayaga Mission Shankaracharya Dental College. Today we are going to see about retention and relapse. Retention relapse, as we all know, orthodontics is in a simple term is the correction of teeth. So we all know how difficult it is to correct the crooked teeth, but more than correction of teeth, it is far more difficult is the retention of the correction. So whatever correction we have achieved, you have to retain that for long time. So that is what we are going to discuss in the upcoming slides. So these are all the contents under which we are going to discuss. So what is retention and relapse, then different schools of thoughts for retention and why relapse is occurring, what are all the causes for the relapse, then what are all the theories of retention and types of retention that has been proposed, and different retainers, both active and passive retainers, we are going to discuss. Have a look at this simple cartoon picture. So see this is what before the treatment, and imagine this is what is after the treatment, and the last one is the retention phase. If the retention phase is not followed, this is what you will end up in. That is, whatever treatment result you have achieved will be lost if the retention phase is not proper. So kindly note down that retention is one of the most important phase in your orthodontic treatment. So what is retention? According to Moyers, retention is maintaining a newly moved teeth in position long enough to aid in stabilizing the correction. So after stabilizing the correction, you have to maintain the position in the newly moved place so that it will have the enough time to hold it in that position. So that in a simple term, Moyers has defined retention as maintaining newly moved teeth in position long enough to aid in stabilizing their correction. So what is relapse? If you are not able to maintain that newly moved position for a long time, then you might end up in losing the orthodontic treatment correction whatever you have achieved. That in simple term is called relapse. So relapse is nothing but a loss of any correction achieved by the orthodontic treatment. So moving forward, there are different schools of thoughts of retention. So what are all the schools of thoughts? This might be your short note question, so kindly take a note. So there are 4 schools of thoughts: occlusal school of thought, apical base school of thought, mandibular incisor school of thought, and musculature school of thoughts. I don't want to complicate much, so I am giving it a simple example. So take a look at this. First is occlusal school of thought. So occlusal school of thought is given by Norman Kingsley, who is called as the father of orthodontics. So according to Norman Kingsley, if you have a proper occlusion after that correction has been achieved, then this itself acts as a best retainer. So proper occlusion should be the key at the end of your treatment. So then retention will be good. That is what according to Kingsley is. Then coming to apical base school of thought. So apical base school of thought, you have to remember 3 names: Alex Lunstorm, Macaulay, and Nance. Alex Lunstorm simply proposed that apical base is the key for your retention, whereas Macaulay elaborated that and told that this intercanine and intermolar width in a permanent, it cannot be altered permanently in any patients. So if you alter that, there is high chance that you will end up in retention, loss of retention, that is more chance of relapse. Then according to Nance, the arch length cannot be altered permanently in any type of malocclusion. Then that is to be considered if you are considering the apical base school of retention. Then coming to third one, that is the mandibular incisor school of thoughts. What is the mandibular incisor school of thought? This was proposed by Greaves and Tweets. I'll give you an example. So Tweets, you all would have known about the Tweets diagnostic triangle. In that, what is the key? Mandibular incisor. Same way, according to Greaves and Tweets, your mandibular incisor is the key for your retention. So what they proposed is your mandibular incisor, this lower incisor should be either perpendicular or retroclined at the end of the treatment. So it should be 90 degree or less than 90 degree compared to your mandibular plane at the end of the treatment. Then your retention will be stable. Then you will have a successful retention. So that is what in a simple term about the mandibular incisor school of thought proposed by Greaves and Tweets. Whereas final one is the musculature school of thought, which was proposed by Roger. So Roger, I used to give this example for students to remember. So musculature means Roger. So you can simply remember Roger Federer, who is a famous tennis player who need a muscle. So for each tennis player need a perfect muscle to smash the ball. So that you can remember Roger for a musculature school of thought. According to Roger, the musculature school of thought, the muscles is the key for your retention. So stability of your circumoral muscles should be achieved after the treatment. If it is achieved, your retention will be successful. That is, your post treatment results will be stable for long time. So simply, schools of retention are 4 types: occlusal school of thought by Kingsley, apical based school of thought by Alex Lundstrom, Macaulay and Nance, then mandibular incisor school of thought by Greaves and Tweeds, then musculature school of thought which is given by Rogers. Then moving to cause of relapse. What are all the causes that are producing the relapse, that is loss of retention? What are all the causes? So first thing is your key element, that is your periodontal ligament traction. When you move a teeth from one place to other, there is a periodontal ligament, primary principal fibers of periodontal ligament and the circumgingival fibers around that all will get stretched, so it will tend to return to its original position. This stretching is the main reason for particular relapse. Then the periodontal principal fibers takes 4 weeks to accommodate in a new position, whereas supragingival fibers will take 40 weeks, as long as 40 weeks to reorganize around the new position. So that is why retention period, that is the newly moved teeth, should be maintained in a particular position for these many weeks to achieve a normal retention. So first is periodontal ligament traction. Then the coming to the second, which is the most important, is the growth. So growth, continued growth in class 2 and class 3 patient after the correction is the more chance for, is the main reason for your relapse. So continued growth should be considered and it should be identified and it should be given a concern while treating the patients. For example, in a class 3 post retention, you can use chin cup to control the further growth of mandible forward. Likewise, growth also should be considered during your retention. Then coming to the third one, this is the bone adaptation around the newly moved position. See this example, the newly moved position, there will be combination of resorption and deposition whenever the tooth movement occurs. So this resorbed bone has to be given time to readapt around the new position. So if it is not given, then there is high chance you will end up in relapse. So bone adaptation is another one important cause for your relapse. Then there is muscular, as we have explained already in the muscular school of retention. There are hundreds to thousands of muscles around your face. So these muscles should be in a balanced state at the end of the treatment for your retention. So this can be if there is imbalance between these muscles, there is high chance of relapse. Then coming to the next one, that is the continued eruption, that has to be addressed. So this was the causes of relapses. Coming to the theories of retention, there are totally around 10 theories. First 9 theories were proposed by Riddle and the 10th one, that is given by Moyer. So this is a common mnemonic which we used to read when we were preparing for our exam. So I hope this will be helpful for you. So kindly remember these mnemonics: MCOC, then again OC, and then big fat. MCOC big fat. You can remember this, and I have proposed the keywords based on my experience. This will be helpful for you to remember this 10th theorem. So remember, first 9 theorems were proposed by Riddle and the 10th one which was added by Moyer. So according to this MCOC big fat. So first theorem, what is the first theorem? Consider this as a keyword, M. So moved teeth. Teeth that have been moved tend to return to their former position. That is the commonest reason why you have relapse. So teeth that have been moved tend to return. So M as the key factor. Then second theorem is C, cause. Cause of the malocclusion should be eliminated, that can prevent your relapse. Then OC, first OC is overcorrection. Malocclusion should be always overcorrected as a safety factor. Then again OC, that is your occlusion. Proper occlusion is a potent factor in holding the teeth in their corrected position. So this will be your fourth theorem. And fifth theorem, that is big fat, B. B is bone and the adjacent tissue. So as I have explained earlier, bone and the adjacent tissue must be allowed time to reorganize around the newly positioned teeth. Then sixth theorem, here the key point is I, that is your incisor. Lower incisor are placed in upright over basal bone as they are more likely to remain in good alignment. Then G, what is G here? Growth. So correction carried out during growth are less likely to relapse. Then fat, F. F is farther the teeth moves, lesser is the risk of relapse. Then A is arch form. Arch form cannot be altered, particularly in the mandibular arch. It cannot be altered permanently by using an appliance therapy. Then T. What is the T? Many treated malocclusion always require a permanent retaining device. So these 9 theories, first 9 theories were proposed by Riddle, and the last one, that is many treated malocclusion need a permanent retaining device, which was given by Moyer. So please remember these mnemonics MCOC2 big fat for theories of retention. So moving forward, there are 6 keys of lower anterior retention given by Rayleigh Williams. See this first one. First key is A. Point A to pogonion. This line will be there. So your lower incisor should be at the AP line or 1 mm ahead of this AP line at the end of the treatment. Then the second one. This is the always your root apex should be distal to the crown of your mandibular incisor. Whereas third theorem is the canine. Canine root apex should be always distal to the crown of a canine in your mandibular incisor at the end of the treatment. Then your treatment will be stable, and all the 4 lower incisors should be in the same anteroposterior position at the end of the treatment, and canine can be little buccal to that of your lower incisor at the end of the treatment. That will be your 5th key. And the 6th key is interproximal stripping or interproximal reduction is always most of the time necessary at the end of the treatment between the lower incisor to achieve a proper stability in the lower anterior. So this is the 6 keys of lower anterior retention proposed by Rayleigh Williams. First is considered to be the AP line. Your lower incisor should be at the AP line. Second, regarding the position of the root apex. So second is about your lower incisor root should be divergent. It should not be convergent like this. It should be divergent for the stability of your lower incisor retention. Then third is your canine also should be, root apex should be distal to that of your crown tip. Then anteroposterior position, all the 4 incisors should be in the same anteroposterior level, and your canine should be buccal to that of the lower anteriors. And the last one is interproximal reduction, or commonly called as proximal stripping, which will be necessary in the lower anteriors. Moving forward, there are different types of retention based on how long you need retention. It can be classified as natural or limited no retention, or limited or short term retention, or prolonged or permanent retention. There are different types of malocclusion that requires need not have much of a retention period. Limited retention is enough. There are other type of malocclusion which require prolonged or permanent or long term retention. So based on the type of malocclusion, you have to take a decision. For example, this is given: if an anterior crossbite is corrected and achieved a correction of anterior crossbite with a proper overbite, there is no chance it might go back because of the proper overbite. That lower anterior stops the backward movement of your upper anterior. So these type of correction of anterior crossbite with achieved proper overbite can come under your natural or limited retention. There is no retention. Whereas if the occlusion is not stable after the correction of your crossbite in posterior area, you need to have a prolonged retention. If the occlusion is proper, that can come under limited retention. So correction of crossbite without proper occlusion comes under your prolonged retention. Then generalized spacing comes under your prolonged or permanent retention. Then simple midline diastema comes under your prolonged retention, and rotation correction comes under the prolonged retention. So remember one thing: after rotation correction, it is always better to do a CSF. So what is CSF? Circumferential supracrustal fibrotomy, which is called pericision. So remember that pericision or circumferential supracrustal fibrotomy, CSF, which is given by Edward, is done after a rotation correction. So moving ahead, we are going to discuss about the different types of retainer that are available. So first one on to your left is called Hawley's retainer. So Hawley's retainer is given by Hawley in the year 1920s. It has simple Adams clasp and a labial bow. So this acts as a normal and most commonly used retainer. So this is Hawley's retainer. Then you have a Begg retainer. Then you have a clip-on or spring aligners or wrap-around retainer. So these are all example for removable retainer. This can be removed by the patient unworn. Then there are fixed retainer. That is, on a simple term, it is a fixed lingual retainer fixed onto the lingual surface of the teeth, curved along the lingual surface, and is bonded. So it is called as fixed lingual retainer or bonded lingual retainer. This is most commonly used among our fraternity. So most orthodontists prefer to use the lingual retainer as a retaining devices. Then there are examples as band and spur retainer. This can be used as a, this comes under an active retainer. This can give you some amount of minimal correction if in case recur in the anterior directions. So coming to the recent advances, there are few examples that I wanted you people to remember. In aligners, which is commonly used now, these aligners provide something called as Vivera retainer. Just remember the names. Vivera retainer, this is something similar to your SX, but this company provides a Vivera retainer. In Align Technology company, that is after Invisalign treatment, they will provide Vivera retainer. Then there is something called Memortine, that is nothing but a fixed lingual retainer, which we have explained already, but in this case it is made up of a night eye wire which is curved and adapted to the lingual surface of the each teeth, and it is a CAD CAM technology, so it is individually made for each teeth. After scanning after the correction is achieved, you can scan the teeth and you can customize this. So Memortine is simply as a memory retainer that is made up of night eye wire. Then there are vacuum formed retainers that are commonly used, known as an SX retainer, that can be also be used. So these are all recent advances, and I want you people to remember these things. That's it. Thank you so much for your patience listening. Thank you, students. Thank you.